Arora? Okay, please come. So your topic will be a rare case of direct carotidocavernous fistula with partial involvement of sixth nerve. Please start your talk.
Good afternoon everyone. I am going to present a case of direct carotid cavernous fistula with partial involvement of sixth nerve. My patient is a 20-year-old male with complaints of drooping of right upper eyelid and redness in right eye since 1 month, and he had forward protrusion of right eye since 20 days. He met with a road traffic accident and which led to injury to the head, and he had loss of consciousness and vomiting, and which led to swelling, redness and drooping of right upper eyelid, and 20 days later there was forward protrusion in right eye. He also had double vision on opening his right eye and whooshing noises in the head on his right side. There was history of headache on and off, severe in intensity, involving the frontal region, and there is no history of pain in the eye or variation of protrusion of eye with posture. Past history and general examination, nothing significant, and systemic examination, oculomotor nerve, trochlear, trigeminal and abducens nerves were not intact. And on diffuse light examination, his eyebrow was raised on the right side and there was drooping in the upper eyelid in the right eye. On ocular examination, uncorrected visual acuity in right eye was 6/9, best corrected visual acuity was plain 6/9. Pupillary reactions, pupil was mid-dilated and fixed in right eye. On non-contact tonometry, pressure was 21 mm Hg, and on applanation tonometry it was 24 mm Hg, and there were increased ocular pulsations seen in Myers, and corneal sensations were decreased in all quadrants. In left eye it was into the normal limits. On slit lamp examination of right eye, we can see the conjunctiva is congested and with tortuous vessels coming towards the limbus, and there was mild chemosis present nasally and temporally. Cornea, anterior chamber, iris was normal, and pupil is mid-dilated and fixed. On ocular movement examination, there was limitation in all the gazes in right eye, more towards the levo side. On inspection, in the worm's eye view and Nafziger's view, proptosis was also present in the right eye. On palpation, on retropulsion test, resistance was felt and orbital pulsations were felt. On auscultation, bruit was there. And on gonioscopy of the right eye, columns of blood vessels were seen in Schlemm's canal in nasal and temporal quadrants. MRI of both the orbits was done and there was dilatation of superior ophthalmic vein was seen. Diagnosis of right-sided traumatic direct carotid cavernous fistula was made. Management, first procedure was done, embolization was done in September 23, and after post procedure, these were the photos of which I could get from the patient. And then second procedure was done in October 23 through transfemoral axis. Guider was placed in right internal carotid artery, and runs were revealed remnant CCF with forward flow into superior ophthalmic vein, and venous access into superior ophthalmic vein was obtained via facial vein, and coils were again placed in the vein. Then check runs post coiling revealed complete cessation of flow into superior ophthalmic vein. And this is the post-op photo after the second procedure which I could get from the patient. And concluding, studies have reported an incidence of 0.2% in case of direct CCF in patients with traumatic brain injury and up to 4% with skull-based fractures. Results of embolization for direct CCFs are favorable with successful angiographic closure in up to 93%. And recurrence is rare but more common in younger patients, and it should be suspected in a patient with recurrence of diplopia. And intervention should be done as early as possible in cases of direct carotid cavernous fistula. Thank you.
Thank you, Dr. Kriti. It was a nice presentation. So, what ocular findings did you notice here?
Ma'am, complete ptosis in the right eye, and ocular movements were limited. Then ma'am, pupil was dilated and fixed, and conjunctival congestion, chemosis was there, and ma'am, on applanation tonometry, pressure was raised and I could see increased ocular pulsations in the manner.
So why sixth nerve is affected in a CCF?
It is in the near to the sympathetic chain, sixth nerve is present in the cavernous sinus. So it is most commonly involved. Sixth nerve is most commonly involved in a case of involvement of cavernous sinus.
But in your case, it is
There is
presented.
Yes,
Is
ma'am.
it rare presentation? Ma'am, anything?
But you said in the paper like partial involvement of sixth nerve. But
Yeah.
whatever you featured, I think complete involvement or partial it was.
Sorry, ma'am.
Your
Ma'am,
case is partial involvement of sixth nerve palsy or complete?
ma'am, partial.
Partial.
Yes, ma'am.
Okay. What are the main causes? Usually cavernous fistula, CCF causes?
Ma'am, most commonly traumatic cause is there. Then spontaneous can also be there due to any collagen vascular diseases, Ehlers-Danlos syndrome, and any history.
Traumatic or spontaneous?
Yes, ma'am, traumatic and spontaneous.
And spontaneous one most commonly seen in postmenopausal.
Postmenopausal, yes, ma'am, females.
That you have to see. Okay. And treatment vision, you have not mentioned anything? Complete
Actually,
recovery, but
the patient was lost to follow-up, so I could just get the photos from him directly.
usually they get 6 normal.
Yes, ma'am.
Okay. Thanks.
Thank
The
you.
results were gratifying. Very good.
Thank you, sir. Thank you, ma'am.
Our next speaker is Dr. Anjali Sharma is present? No. Dr. Kalyani? Okay, please come. Her topic will be double trouble in an infant with sudden onset bilateral esotropia.
Good afternoon everybody. Today I'll be discussing about a case of a 15 months old girl child who presented to our clinic with a sudden onset inward deviation of both the eyes. The symptoms were present in the past 3 days and the deviation is constant, and throughout the day there were no cyclical or diurnal patterns to that. We just had the child had a positive history of fever, vomiting, diarrhea just 8 days prior to this deviation of eyes. The child was in treatment with the pediatrician and the fever, vomiting and diarrhea subsided within 2 days of the treatment. There was no other significant history. Apart from that, the child is very irritable since the past 8 days. So as this esotropia is sudden onset, we asked the patient for the old photos of the patients which were orthotropic as shown versus the current photo at presentation which had a large angle esotropia. So the child's vision was following and fixating, and as it is sudden onset, again we had to rule out any accommodative factors. So we did a cycloplegic retinoscopy for the child, but it did not reveal any refractive error. On doll's eye maneuver, the child, there was absolutely nil abduction, that -4 abduction limitation in both the eyes. We also did a neurological assessment for the child which was normal. Strabismus examination showed bilateral large esotropia. The anterior segment showed the pupil was sluggishly reacting. Everything apart from that was normal. So we dilated the patient and had a look at the fundus. So the discs there was blurring of disc margins, vessel obscuration at the disc margin, and a hyperemic disc which was suggestive of papillary edema. So to investigate this, we in conjunction with the pediatric neurologist and the radiologist, we did an MRI which was normal. The routine lab tests were also normal. We also did a lumbar puncture. So the opening pressures were 30 centimeters of water, and the CSF studies were normal. And we also did one novel investigation which is the optic nerve sheet diameter. So the optic nerve sheet diameter was 5.3 on both the sides, which is raised, with normally 4 is the cutoff for this infant. In treatment, we started with oral acetazolamide to control the raised intracranial pressure. And for the esotropia part, we injected 2 units of Botox in each medial recti. After that, we found that there was almost complete resolution of the esotropia. This is a 2 months post-op of that patient. And also on doll's eye maneuver, you can see that the abduction is full. So what we already knew is that pediatric IIH is very rare, although we have to warrant a high level of suspicion. It is mostly managed by the pediatricians and the pediatric neurologists. But what is our role here? What we as ophthalmologists are doing here is we could actually make use of newer modalities which are minimally invasive. It is our role to make the child like this go into orthotropia. So I would like to focus on the non-invasive investigations, which is the Botox, which was given in this case. As the development of MR contracture happens, this age is highly susceptible for amblyopia. Giving a Botox really helps, and also the optic nerve sheath diameter. It can be done routinely, especially in a critically ill patients or children, where it can be done as an extension of physical examination as well. So as it was our first case, we went ahead and had a look at the literature. So there were actually many patients with pediatric IIH, but the features were different. Like as we say, female fat in 40s have IIH, but in children the risk factors are different. There were many studies on optic nerve sheath diameter also, which is as equally good investigations. So the pediatric IIH, the clinical features are less aggressive, cranial nerve palsies are associated with it, visual loss is lesser, and papillary edema subsides on its own. Thank you.
Very good presentation.
Thank you, ma'am.
So did the child had any history of fever or any other
Yes,
viral
ma'am.
infection?
Yes. 8 days ago, 8 days prior to the sudden onset esotropia, child had a history of diarrhea.
Did you follow up the case for how many?
Yes,
what
ma'am.
is
The
follow-up
child
period?
is still under follow-up.
Okay.
Yeah, the child has maintained orthotropia sensor, and the papillary edema also resolved. Around it resolved slowly, but over the period of 4 to 5 months.
So any viral infection also can lead to.
Yes.
So one time opening pressure was high.
High.
And after that, how you managed? How the pediatrician?
Yeah, they
managed
started them on syrup acetazolamide, 25 mg per kg according to the weight. So that was continued for almost about a month. And after that, we found a regression of the papillary edema. After that, they stopped.
So MRV was done here.
No, ma'am. Only MRI was done. Once.
On
Yes.
MR venography was not
No, MR venography
associated
was not
in this
done.
case.
Yeah.
Okay, ma'am.
MRI was normal.
Yes, ma'am. The MRI was normal.
So botulinum toxin you gave,
Yes, ma'am.
like waited for edema to recover, or like how many days after the starting of acetazolamide?
Ma'am, once the patient came back with all the investigations done and we were sure of the diagnosis, we gave the child Botox within 7 days.
After 6-7 days.
Yes, ma'am, after 6-7 days of presentation because of the MR contracture.
And
Yeah,
reason of IIH anything? Idiopathic only.
Yes, ma'am, idiopathic, just that he had a
But
history of.
associated with fever and all. that's
Yes,
what.
yes.
CSF study done?
Yes, ma'am, CSF
Normal.
studies came out to be normal. Opening pressure was high though.
How do you relate your fever with IIH? Could it be an optic neuritis, bilateral, like you see in meningitis, etc.?
Yes.
Why not that?
Firstly, sir, because of the optic nerve sheath appearance, there is the typical obscuration at vessel margin, and whole appearance of the optic nerve was like more like papillary edema rather than optic neuritis.
But you mentioned pupil was sluggish reacting.
Yes,
or
ma'am.
that?
Pupil were both the pupils were
And
sluggishly
as it was
reacting.
a child vision, you assessed vision.
Only till following and fixating, and we asked the parents, is there any difference in the reaction of child?
So very close DD can be viral as precedent viral infection was. So it can be a very close DD.
Yes, ma'am.
Thank you.
Thank you, ma'am.
Dr. Samuel Momin is here. Okay, please come. So his talk will be third nerve palsy in pituitary adenoma.
Good morning, everyone. I'll be presenting a case on third nerve palsy in pituitary macroadenoma. This is the consent of my patient. My patient is a 35-year-old female. She had history of drooping of left eyelid since 15 days, which was insidious in onset and gradually progressive over 5 days. It was also preceded by headache, which was mild and mostly confined to the left side. The headache was recurrent of about 2 to 3 episodes in a day, but it was non-radiating. Negative history. The patient has no such similar complaints in the past, no history of trauma, no recent history of fever, muscle fatigue, ocular surgery, any gait abnormality, projectile vomiting, or aura of photophobia. general examination of the patient were within normal limits except third cranial nerve, which was found to be in palsy. On diffuse torchlight examination, complete ptosis of left eye could be seen. Vision in her right eye was 6 by 6 and left eye was 6 by 9. And on best corrected, it was 6 by 6 and 6 by 9. Pupil reaction in right eye was normal, left eye was fixed and dilated. Anterior segment and fundus were well within normal limits. This is the photo of my patient. This is a 9-gaze picture of my patient where we can see that there is complete restriction of movement in the left eye in all gazes, and it's mostly down and out in all of the gazes. FDT and FGT is negative. Prism bar reflex test shows left eye exotropia with 30 PD with hypertropia of 10 prism diopters in both near and distance. Word for dot test, the inference was the patient was having crossed diplopia, and on diplopia charting we can see that there was cross diplopia with maximum separation in dextro elevation. Hess charting, we can see that there is overaction in the lateral rectus, and there is restriction in all of the muscles in the left eye except the lateral rectus. Her glucose was within normal limits, was 98 milligram per DL, and rest parameters were also normal. On MRI, we found a well-lobulated, homogeneously enhancing solid lesion involving sella and suprasellar region with extension into the left cavernous sinus. She was diagnosed as a case of pituitary macroadenoma as per NOS classification system with grade 3A. The patient was then admitted in neurosurgery on 10th of April for about 3 weeks. A provisional diagnosis, my patient was provisionally diagnosed to be a case of oculomotor nerve paralysis with pupil involving due to pituitary macroadenoma. Management was a transnasal resection of the pituitary adenoma by the neurosurgery department. She was operated on the 18th of April 2024. This is the post-op picture. She was still having complete ptosis, and this was the 9-gaze photo on post-op day 4, and she was still having restriction in all gazes in left eye. The third nerve, cranial nerve, oculomotor nerve, has two components, parasympathetic and somatic. The third nerve palsy has a variety of etiologies which may be due to different underlying pathologies like ischemia, tumor, trauma, hemorrhage. It may be congenital and idiopathic as well. Patients presenting with pupil involvement are usually due to compressive causes like tumors and aneurysms, and pupil sparing cases are seen in case of ischemic cause. We describe a case of 35-year-old female with pupil involving third nerve palsy. She presented with left eye complete ptosis, down and out eye in left eye, and ipsilateral headache, which was only left-sided. MRI revealed a pituitary tumor extending into the left cavernous sinus, which led to the compression of oculomotor nerve. Patient was then transferred to neurosurgery department at our hospital and was taken up for surgery. Thank you.
Did you test the field test shown here or perimetry?
Yes, ma'am, but actually we did the perimetry, and actually I didn't include it in the slides because it was getting too lengthy. So,
Okay,
but
so
yes,
what about fourth nerve?
Ma'am, fourth nerve, I looked for fourth nerve, it was intact. I asked the patient to look in dextro depression, and I looked for a small mole which was present on her near the limbus, which I could observe that it was moving by a few degrees, by a few clock hours when she looked in dextro depression.
It is already third nerve palsy is there.
Yes, ma'am.
So in a third nerve palsy, how will you test for fourth nerve?
For superior oblique, ma'am, we'll identify a mark which may be present on the eye and observe the movement of that mark. When we ask the patient to look, in this case I asked her to look in dextro depression position, ma'am. So I saw that the
Very simple
mark
test in slit lamp also. Because already out and down
Yes,
eyes, so third nerve. You can see the conjunctival blood vessels also
yes, ma'am.
to see the degree of torsion. Sir, madam.
But I don't understand, you started with the patient complaint, fever, headache and all that. What is the cause?
Ma'am, she initially presented with complete ptosis in her left eye, and she also had headache, ma'am. The headache was not so severe, so she was ignoring her headache. But after a few days of headache, then she suddenly had she had complete ptosis of left eye, which progressed gradually over 5 days, ma'am. After which she presented to our OPD in the IOPD, and then we worked up the case accordingly.
No, is it because thromboepulsy could be related to fever, viral thromboepulsy? Can be possibilities
Yes, ma'am.
there?
But she had negative history of fever, and
No, you said she had fever, vomiting, headache.
ma'am, it was in negative history actually.
Okay.
In negative history. Okay.
Thank you, ma'am.
Okay, thank you.
Dr. Tanima, who is there? No. Dr. Ritika Singh. Her case will be a rare presentation of neurocysticercosis in young patient of Uttar Pradesh.
Good evening, respected seniors and my juniors. Thank you for this opportunity. Today I am going to present a rare case of neurocysticercosis in young female in Uttar Pradesh. So she is a 22 years female resident of Meerut with low socioeconomic status. She presented in mid-April 2024 with chief complaints of double vision when both eyes were open since 1 month, diffuse headache for 15 days, and sudden onset of deviation of left eye inwards for 4 days. So as stated by her, she was apparently asymptomatic 1 month back when she noticed binocular diplopia, diffuse headache for 15 days, which was not associated with vomiting or nausea. There was sudden onset of deviation of left eye inwards for 4 days. So she also told us that there was history of miscarriage 1.5 months back. There was no history of trauma, fever, seizures or intraocular surgery. There was no history of similar illness in past. She's a non-vegetarian by diet. It was a non-consanguineous marriage. On general and systemic examination, she was an average build, well-nourished, conscious and well-oriented to time, place and person. Other systemic findings were within normal limits. There were no focal neural deficits. On ocular examination, position of head was straight while looking forward. Gaze was orthophoric. And on further examination, she had normal extraocular movements. Only I noticed there was mild hyperphoria in left eye. On a Snellen star, she was 6/6 with pinhole. She improved to 6/5, and near vision was N6. On Hirschberg test, she was orthophoric, and anterior segment evaluation on slit lamp was within normal limits. Her intraocular pressure was also normal. On fundus evaluation, she had no abnormality. Optic disc was also normal. So what to do next? So we went further ahead with systemic investigation. She had normal CBC. Montu test was negative. We did torch examination. That was also negative. Chest X-ray, no significant finding. And we also did pure tone audiometry. It was also normal. So on further evaluation, on further investigation, we went ahead with contrast enhanced MRI brain with orbit. So you can see there were multiple lesions, hypercystic hyper lesions with surrounding hazy margins in both the hemisphere, more in right, also in frontal lesion. And also in sagittal section, you can see they were also present in pons as well as cerebellum. And there was cystic lesion with eccentric hyperintense nodules suggestive of scolex. So the diagnosis is neurocysticercosis. So after neuroconsultation, we started her on oral prednisolone. Her weight was 65 kgs with antacid. And on day 3, we started her on oral albendazole 400 mg. So after 1 month, she improved drastically. So beautiful response after steroid. We can compare. Surrounding edema also reduced. Number of lesions has reduced. Both the axial scans, and also we can see in this coronal scan also number of lesions have reduced. So keepers are basically, we have to be suspicious in postpartum diplopia and headache cases. We have to investigate thoroughly. We have to be vigilant. Early neuroimaging is very much appropriate in especially in non-vegetarian females, and there must be awareness among general practitioners as well as gynecologists that even in absence of seizures, they must be thorough enough if she complains of either headache or diplopia or both. Thank you.
Thank you. You said patient came to you with inward deviation.
Yes, I noticed there was no, actually there was no inward deviation, only she
So
complained.
it was her complaints. only.
Horizontal recti were normal.
And the movements were also, you said, normal.
Yes, yes.
Thank you.
Thank you.
Thank you.
Thank you.
Shruta Kirti Porida, Dr. Shruta Kirti. She will present BBSOS, a rare case report and literature review.
A very good afternoon to one and all. Today I will be presenting a rare case of Bose-Bone-Starr scalp optic atrophy syndrome, a rare case report and literature review. I have no financial interest to disclose. So coming to the introduction, BBOS is a rare disorder that presents in early childhood with the key features of intellectual disability, developmental delay and visual impairment. It was first reported in 2014 in 6 patients with a worldwide prevalence of 1 in 1 lakh to 2.5 lakhs. Most commonly it is inherited as an autosomal dominant disorder, but few cases have been reported to be inherited mitochondrially. It can be either a congenital or an acquired disorder. The underlying genetic abnormality has been reported to be a heterogeneous mutation in the NR2F1 or COF-TF1 gene which disrupts the normal neurodevelopmental process because this gene is the key transcriptional regulator of brain development. Coming to the case proper, a 6-year-old male child complained of gradually painless diminution of vision in both eyes since the last 2 to 3 years. His birth and postnatal history was eventful. He was delivered by preterm delivery by C-section at 8 months with a low birth weight. There was delayed birth cry with a history of 2 weeks of NICU stay. There was history of delayed developmental milestones with global developmental delay. On examination, his best corrected visual acuity was 6/60 and he had a abnormal head posture of 25 degrees of right face turn with both eyes moderate amplitude and frequency horizontal jerk in nystagmus with null point in the left case. Rest of the anterior segment examination was normal except for the pupils were sluggishly reacting. On the strabismus workup we found he had a 25 prism diopter of exotropia for distance and near with a -1 adduction limitation. Then we did a humide refraction for the child and he was having compound myopic astigmatism. Glasses were prescribed for this child and then we did a dilated fundus examination which showed a gross temporal pallor in both the eyes. Then we ordered MRI brain and orbit with contrast for the child which showed mild thinning of bilateral optic nerve with prominent bilateral perioptic space which was consistent with the partial optic atrophy. No optic nerve hyperintensities or enhancement was shown. Then we did other investigations and then whole genome sequencing was done which was suggestive of heterogeneous deletion in the NR2F1 gene. Pediatric consultation was done to confirm the systemic diagnosis. So with all this, a final diagnosis of Bose-Bone-Starr scalp optic atrophy syndrome was done. Coming to the literature review, various cases have been published on the expanding clinical phenotype of BBOS syndrome and till date literature reports 200 cases of BBOS with various phenotypical and genotypical variability. The important systemic features include developmental delay, speech delay, intellectual disability, seizures, hypotonia, hearing impairment, repetitive behavior, autism spectrum disorder, dysmorphic facial features and oromotor dysfunction. Whereas the important ocular features include optic atrophy, optic nerve hypoplasia, cortical visual impairment, nystagmus, amblyopia and significant refractive errors. The neuroimaging findings most important are the thinning of the corpus callosum, widening of posterior horn of lateral ventricle and abnormal development of the hippocampal commissure and thalamocortical projections. So the management is mostly supportive. Recommended therapies include visual therapy which is focused on CVI, physical therapy to improve the gross motor skills, occupational therapy, speech therapy, Then behavioral therapy if the autism spectrum disorder is diagnosed, and if the patient has seizures, then anticonvulsive treatment has to be given. So the take clinic message from this presentation is BBSOS is a neurodevelopmental disorder with greater phenotypic and genotypic variability. A thorough understanding of the clinical entity is a must. The clinical description in combination with experimental research and genetic analysis will allow for a better comprehension of this rare syndrome. And one of the key questions which we need to address is to what degree BBSOS is due to altered neurodevelopmental versus neuronal homeostasis. Thank you.
Okay. So was I audible without microphone? Thank you again. So anything else you want to discuss, sir? Very nicely documented, and this is a very rare case, as we know. These
Actually,
symptoms,
one important rare thing we found that like these patients, they have a very love for music and they have a high pen threshold.
Okay.
So when the injections was given for the contrast also MRI, the child didn't complain of any pain. Though the child was a 6-year-old child, he didn't have any complaint of pain like other children.
What was the visual acuity? I forgot.
BCVA was 6/60.
6/60.
And corrected was 3/60.
For how long time you were following the child?
The child is still under follow-up. He is having vision therapy with us and also physiotherapy he is having in our hospital. So he is still under our follow-up. He is wearing glasses with good compliance and he is under our follow-up.
Thank you.
Thank you.
Our next speaker is Dr. Arvind Kumar Maurya, sir. Sir, please present your case. He will present orthoptic improving vision in bilateral optic atrophy with hyperhomocystinemia and exotropia.
Good afternoon, respected chairpersons and my dear friends. So we have this orthoptech for the treatment of amblyopia, and I don't go into the detail. Next. It's not moving forward. Yeah. So this is the device, is the most economical device and the best option for the treatment of amblyopia. And we thought that we can use it in the other indications also, like the sixth nerve palsy, partial third nerve palsy, Alzheimer and hyperactive children, attention deficit disorders. So the hypothesis is all about the top-down impulses originate in the prefrontal cortex and alter the attention mechanism, which in turn affects the striate cortex. And this is how it is happening. There is sudden appearance of light, stimulation of the saccadic movement in association with the stimulation of the fovea and the V1 via the top-down impulses, and suppression of the retinal area between the fovea and peripherally stimulated retinal points. And these repeated stimulation of the magnocellular cells via the attention area and parietal cortex leads to stimulation of fovea, and then prosaccade is associated with maximal stimulation of the V1 area. So this was a boy of traumatic optic atrophy, 16-year-old, vision 636 part, near vision N12, disc failure, right eye color vision 6/17, left 5/17, stereopsis of more than 400 second of arc, contrast sensitivity also reduced 1.2.
Check. PC. Pettu.
Other investigations were also done. So MRI shows thinning of the bilateral optic nerve, vitamin B12 were normal, but there was hyperhomocystinemia. And these were the visual field perimetry management. So we started 1 week orthoptech therapy, tablet citicoline, 500 mg BD, and tablet methylcobalamin also given. And for the hyperhomocystinemia, it was treated by the physician using the folic acid. So this is how it is done for the problematic eye with a good eye pass for 20 minutes and repeated with the good eye open and amblyopic eye pass for 5 minutes. So we use the same thing in the optic atrophy but alternate. So it was 20 minutes for one eye and 20 minutes for the other eye. And after 2 weeks of orthoptech therapy, the patient improves. Right eye vision improves to 6/12.
Come on then.
7, 4, 6.
Bit louder.
Improved to 200 second of arc. Near vision improved
Okay,
to
good boy.
N5.
This
5, 7, 4, 6,
and this
5, 7, 3, 4, 3.
and this. No? Try it out. Try it out. Can you read
The
out
other eye?
S
this?
D Z K
And now the
N
And of course, there is a role of functional bold MRI that must be looked into. So significant improvement was there in the vision, stereopsis, in the hand-eye coordination. Also, it helps in improving the self-confidence. We have tried in few nystagmus cases and the results are really good. So these are my references. Thank you so very much.
Thank you, sir, for this nice
Thank you.
presentation. Sir, please.
You said he gave history of trauma, and so there was other abnormality also, or only optic atrophy was seen?
Optic atrophy along with exotropia.
Okay. So
Yeah, and hyperhomocystinemia.
but hyperhomocystinemia is not related to trauma.
Yeah, it's not related to that thing.
That was a
That
chance
was-
finding.
Yeah, accidental finding.
Incidental
Yeah,
finding.
yeah,
So with this system, the patient improved. That is
yeah,
very good.
improved.
How many patients have you seen or have you treated? Like
I have treated more than 5,000 patients of amblyopia, and these nerve disorders, it's more than 100.
basically, you are using it for amblyopia.
It's innovation
Because
by
this is something new to us.
Dr. Santhanas Gopal. So it's basically for amblyopia. So when we have nothing, so we thought that we can try this thing also. So we tried in different indications. So for this orthoptic,
Sir, trauma history is how many days? Trauma
5 years
history?
back. It
5
was in the
years
first
back.
slide. Yeah, 5 years back.
Okay. And only 2-week course is.
Yeah, it is given for 6 months, but for 2 weeks it needs to be given every day.
Written. No, you
So
have
we admitted
you
the
have
patient.
recorded after 6 month
Yeah,
therapy.
yeah. So we admitted the patient and then we started with this.
I
Okay.
think
Very.
even if you say about amblyopia, we most of the times say that no, nothing can be done.
I should say after 5,000,
Everybody should.
after
start
treating 5,000 of the patient, I would like to share my experience that it's just a relative term. We have even treated the most rigid, the plastic patient, 56-year-old. They had also improved.
Of amblyopia.
Amblyopia
Yeah.
therapy has progressed a lot, but optic atrophy, this is the
Yeah.
very, if this
optic
is
atrophy is
actually
different.
improving,
Yes.
we are giving also others. Also we are giving, but obviously the spectrum will be increased, and if optic atrophy is
So we have just registered a new clinical trial with the other indications.
will be very good. We'll eagerly wait
All,
to know
all
the
thanks to
should do it.
all thanks to Dr. Santhanas Gopal.
I just like to ask,
Sorry.
So how the visual improvement is there? Now which atrophy test you are taking?
no, AION, multiple sclerosis. That also vision is improving. But what is the reason? How?
Like AION
Mic,
can
please.
spontaneously improve also. So actually our inclusion criteria should be very strict. Like AION presentation after we have seen spontaneous improvement.
That is different.
Traumatic optic atrophy also is also.
Ultimately the problem in the amblyopia is already at the presynaptic, there is the problem. So nitrous oxide is not released because of the glutamate blockage. So optic atrophy also part, if we can revive that thing, semi-dead RNFL are there, so we can work on it and somehow the patients are improving.
Actually, we are giving neurovitamins. Along with that, we are giving the vision therapy. And at least we have seen the minimum improvement of 2 to 3 lines in those patients.
That is also great.
Thank you so very much.
So we have, if anybody can, Dr. Hardik, Dr. Nitesh, those who are absent, I am repeating the name, Dr. Vishal, those who are not presented, they can present, who have still time, they can present. After this. Right now.
Anybody is coming?
Sitting here,
call him.
If you have number, you can call him. He was a 550 more from
I think Dr. Chandan Gopal has published it also. There are so many articles on orthoptics. Yeah. Regarding orthoptic, actually we have a lot of discussion in like it's traditional and good.
next week is coming. So we will conclude the session if none of the other presenters are there. I will request all the participants also please come for a group photograph.